To get started. Good morning, everyone. I hope you can all hear me well. I want to thank you all for attending this presentation, and I would like to thank the organizers for the privilege of addressing this elite group of physicians and professors. I was given an interesting assignment to talk about COVID-19 challenges as it pertains to the relationship between interstitial lung disease and COVID-19. This is interesting because, well, that it was difficult and easy at the same time. It was difficult because, well, there isn't that much out there, and it was easy because there isn't that much out there. So I'm going to try to share with you over the coming 15 minutes what I found to be interesting in a clinical setting on what matters regarding this combination. So as you know, COVID-19 has impacted all aspects of care for patients with interstitial lung disease, including both the diagnostic process, what we usually do to diagnose people with a specific type or form of interstitial lung disease, and of course, what it pertains to the initiation, the maintenance, and the monitoring of our ILD patients and their therapy. So the objective of this overview is to discuss practical considerations for the diagnosis and management of fibrotic ILD during the COVID-19 pandemic. This also includes the COVID-induced fibrotic lung disease. So, because now, as you're all experiencing in your clinical practices, you are dealing with the downfall of COVID-19 on our affected patients in terms of the development of fibrotic diseases and their extent and what we can do about them. So this is obviously a rapidly evolving situation with limited evidence to guide specific recommendations, hence the importance of transitional research and clinical trials. I will touch upon those points at the very end of my presentation with the very interesting gamut of pathways that we can explore. So is fibrosis common with COVID? Yes, it is. Early analysis from patients with COVID-19 on discharge from hospital suggests a high rate of fibrotic lung disease, right? So overall, in a study from the Wuhan experience published in the European Respiratory Journal, I'm not going to mention the year on any of this because it's all 2020. I guess you're aware of that. So 47% of 108 patients that were evaluated had impaired gas transfer. And keep that in mind because this is your gas transfer, so that's reflected in the LCO. And this is what we're seeing primarily in COVID-19 patients. As a matter of fact, I'm sure this is not what I'm here to talk about, but I'm sure you've noticed that proning, which is something that we're used to doing in our patients with ARDS, the classical ARDS, seems to have a much higher impact in terms of improving oxygenation in COVID-19 patients. So the interface, the gas exchange and gas transfer is severely impacted in our COVID patients. And 25% of that group had reduced total lung capacity. So you're talking about two things. You're talking about losing the total lung capacity and by inference, your FVC, and of course the impairment in the gas transfer, which is a hallmark of interstitial lung disease. And obviously this was much worse in patients with severe disease. So what are the diagnostic challenges we have? Well, we have problems that may manifest themselves at all stages: pre-COVID, when they are affected by COVID, and post-COVID. And this applies to two populations, essentially: a population of patients that do not have ILD or any kind of fibrotic lung disease at baseline, and those who already have it, and then they're afflicted by COVID. So I'm going to try to, just go over them as an overview. And my apologies because it's not a very detailed presentation for the lack of time for that. But hopefully, if there are any questions, I'll be able to address them at the end of the presentation. So I'll give an example of something that we're seeing as a common COVID and post-COVID ILD. So I'll give an example of an NSIP case. So this is something that I got off the internet, and this is a standard illustration. I'll go over the details that matter. So it's a presentation, it's a scan from a patient with a idiopathic NSIP, which, my apologies, okay, so which is showing reticular peribronchovascular opacities, traction bronchiectasis, and like you can see, the subpleural sparing. Keep that in mind for the coming couple of minutes. The latter is a classic finding of NSIP, as we all know, right? And this is the same patient where you see bilateral ground glass opacities and subtle reticulations along bronchovascular bundles and in the subpleural lungs. And we have to pay attention to the presence of associated traction bronchiectasis. The combination of findings and the absence of honeycombing suggests that this is the diagnosis we are dealing with. This is one of my patients over the past few weeks, essentially. And on the right-hand side, you see his scan that was done on October 24. And then on the 16th of November, you have the follow-up scan. And we're going to have this over the coming couple of slides. So this is a baseline CT that showed diffuse bilateral ground glass opacities, predominantly in a peripheral subpleural distribution with associated interlobular septal thickening, what we refer to as crazy paving pattern. This is a typical imaging feature of COVID-19 pneumonia, and I guess you will agree with me on that subject and on that matter, albeit with different degrees. And you can see on the left-hand side how it's progressing. I tried to make the cuts almost the same. My apologies if they are a bit off like this one. And then you look here at the bottom of the lungs, essentially. And this is the same patient just a couple of days ago. So this is the same COVID patient, 3 weeks later, supposedly recovered with persistent dyspnea on exertion, right? So this is persistent dyspnea on exertion. Look at the pattern of the more recent changes, so the post-COVID changes. And you can see that this is the same patient, lower cuts. The follow-up chest CT demonstrates increasing extent of the diffuse ground glass opacities with new/worsening fibrotic changes, including, again, subpleural reticulation and traction bronchiectasis. And I highlight the areas of subpleural sparing that you can see. So you can actually appreciate the reason for us to be considering NSIP in such patients, and obviously it's going to create an issue with other patients who already have NSIP or an ILD at presentation in terms of diagnostic dilemma. So this brings us to the diagnosis of ILD. Under normal circumstances, the process takes about a year from symptom onset at an experienced ILD center, which is multi-faceted to dealing with such conditions. Right, so we start with the history and physical exam, get the standard blood work, serologies, autoimmune conditions, etc. We get complete pulmonary function test. We get the imaging with high resolution. We have the MDD discussion. This is an important element because this is being strongly affected by our COVID behavior in terms of prevention. And then the need for interventions, be it bronchoscopic, where you have the higher likelihood of aerosolization versus VATS, for example, depending on the diagnostic challenge. So under COVID, each and every step represents a hindrance, and these challenges we're dealing with. So we're minimizing person-to-person contact at all levels, including, of course, the MDD team members, performing tests safely and adequately and selectively so that we can maximize our diagnostic yield, minimize our exposure, and at the same time, minimize interventions. Now, obviously, this is going to cause a bit of a giveaway. You have to have a trade-off between the diagnostic accuracy and, of course, the safety of the personnel and the patient and yourself, obviously. So this prioritization is a condition that we're living with COVID, and we need to adapt to it at least until we are done with COVID, hopefully in the near future. So we have to make compromises, obviously. And what are those compromises? Well, first of all, we're much more likely to postpone things. In the coming slide, I'm gonna give a diagram comparing where we're compromising at different levels and to which extents. So the drive to perform tests or procedures are currently a function of the urgency of the patient's condition and the need to modify therapy in the short term. We're much more likely to stretch the limits of diagnostics. So your definition of what used to be probable is changed, likely is changed, possible is. So in other words, the algorithms that we used to, based on which decide whether to push forward with more interventions, with more invasive tests, have been modified to accommodate the COVID situation and the stress on the system. So as such, we're much more likely to initiate empiric therapy we wouldn't have done under normal circumstances. And this is especially true if studies reveal a benefit, even marginal, for antifibrotics in COVID. I'm going to touch upon antifibrotics in COVID as well, despite the paucity of the data, but I think that these are important things to go over for our clinical use. So to reiterate the same process, this is a comparison between what we used to use to have as a standard or the normal procedure or process for COVID, for ILD diagnosis, and the COVID modified approach to ILD. So you can see in terms of the initial diagnostics, the initial consultation is preferably done by video conferencing. You have the differential later on in terms of the reliability of the diagnostic tests. MDDs are held virtually, of course. Diagnosis is done with lower certainty because of the risk of contamination and the access to care. And then later on, in terms of invasive diagnostics, you have to weigh the risk of exposing the personnel to aerosolization and at the same time having a stronger or more robust diagnosis. So there is a concern of all the steps and of course deferral of the process whenever we can do that. So in the good old days when we used to deal the standard way of diagnosing ILD, the treatment has been affected by COVID restrictions, including immunosuppressants, access to care, steroid use, the dose, and the timing in terms of the comorbidity with COVID. And then the COVID-related ILD is an ILD patient more likely to contract COVID. Once contracted, is the outcome same, similar, or worse because there is concomitant COVID? Any treatment adjustments in the patient afflicted by both diseases. And then, of course, I will touch, like I said, about patients who had no problems at baseline, developed fibrotic lung disease or interstitial lung disease because of COVID, and whether our interventions with antifibrotic therapy would be likely to alter the outcome. So this is a postulated COVID pathophysiology. You know about this more than I do. I'm going to touch upon it in a second. So it's still unknown completely. We know that it has to do with the ACE2 receptor. That's an important element because in patients who have ILD, especially fibrotic ILD, their number of ACE2 receptors are reduced, and as such, their propensity to getting infected with COVID is impaired. So they are less likely, or at least this is a postulated proposal, they're less likely to contract COVID. But once they do, the outcome is worse, as we will see in a second. So new viral particles are then released, activate the cellular and humoral immune response, and then you have many cytokine, what is called a cytokine storm, if you will, and subsequent ARDS, and even the word ARDS is not accurate. Now we are coining other words like a VDS and to highlight the vascular component here. Interestingly, there was a study that was done in Lille, France recently and published in the intensive care medicine. It looked at post-mortem biopsies from 6 COVID-19 patients at different stages of their disease. Interestingly, 5 of them displayed evidence of AFOP, acute fibrinous and organizing pneumonia, and the finding was fibrin balls, intraalveolar fibrin deposition in their alveolar spaces. So this has implications regarding the aspects of management as well. However, it turns out that immunosuppressant patients did not appear to be at higher risk of severe illness during past coronavirus outbreaks, like the old COVID-1, if you will, SARS, and the MERS in 2013. And immunosuppressed patients similarly do not appear to have an increased risk for the severity of COVID. treatment in ILD, it's reasonable to continue and initiate immunomodulatory therapy in such patients, with the exception of steroids, because we have from the British study on COVID patients that early start seems to convey a worse outcome in COVID patients. So steroids may be important in COVID. They are important. One of the few things that seem to reduce mortality, but timing is key. And therefore, if you want to start immunomodulatory therapies in ILD, it's reasonable to do so. Watch it with the steroids. So do it on a case-by-case basis, or delay initiation if it's not urgent until things are better sorted in the COVID situation. And of course, you have to be careful with the antifibrotic medications, because side effect profile may be of value, and we are anticoagulating our patients, and nintedanib, for example, as one of the major antifibrotics, can cause increased risk of bleeding. So ILD patients with COVID, no robust data again, unclear if more or less susceptible to COVID, but like I said, since those patients have less ACE2 receptors, so maybe they are less susceptible. However, once they capture COVID, they may have a worse outcome, as seen in those two studies published in Lancet and in Lancet Respiratory Medicine, looking at the outcome in patients with COVID. Those patients had a mortality that was between 61 and 97%. So that's very important to keep in mind. Strategies to reduce potential exposure to COVID-19 for patients with ILDs are similar to what we do on a regular basis. So you don't need to worry about the stable, but just to outline that it's a similar involvement. Finally, antifibrotics in COVID lungs, we have pirfenidone and nintedanib. Just forward on nintedanib. Nintedanib, this is a paper that I urge you to read by Peter George in Lancet Respiratory Medicine just recently. And what he's saying is that it seems from a post hoc analysis on the Impulses study that was published in the New England Journal of Medicine, it seems that nintedanib improves the outcome in terms of FVC in the first weeks, so 3 to 4 weeks, and therefore it may have an advantage. Pirfenidone did that, but after a few months, so they kind of coalesce after 3 to 4 months. But that is maybe an interesting point, because this kind of antifibrotic therapy has a very rapid effect. Treatment benefits in other forms of lung fibrosis may be applicable to those in COVID, and efficacy might depend on the combination with anti-inflammatory treatment. And in the same paper, you have a suggestion of pathways whereby you can have targets for future studies, both for the COVID-related ILD and for the standard ILD. I'm not going to go over the details, you can look into them, but just to tell you that there are a lot of studies that are being done in terms of translational research in COVID and ILD. For example, do novel cell-based IPF therapies that improve the tissue microenvironment help treat COVID-19? How about the predictors of mortality in pre-existing ILD and COVID-19, et cetera, et cetera. So I will leave you with that, just to say that in conclusion, COVID is a novel virus with, as of yet, incompletely elucidated pathogenesis. The lungs are the most affected organ with a high frequency of interstitial involvement in affected individuals. COVID itself causes multiple ILD patterns, especially NSIP-like. Patients with baseline ILD may be less likely to contract COVID, but have a worse prognosis once they do. Treatment for COVID-induced ILD is unclear, but antifibrotics may have a role and may be earlier than thought. Research efforts are necessary to better understand this association and how to manage it best. With that, I leave you and I will take your questions, and thank you for your attention.
Can you hear us?
Yes, now I can.
Very good, very good. I welcome Professor Tariq Safwat and Professor Ahmed Al-Halafawi. Share this person. Please, Professor Tariq.
Good morning. You hear me, Professor George?
Yes, sir. Good morning.
How are you?
I'm good.
And we really appreciate this collaboration with the Pulmonary Lebanese Society. And hopefully by next year, that won't be a hybrid meeting, that will be a physical meeting either in your lovely country, Beirut, or in Egypt.
With pleasure.
And all my best regards to the whole group, Judy Bahous, Musa, and my very dear friend Salah Zainuddin with his nice car, his Porsche car. Send them my very best.
Thank you for involving us in this activity. It's amazing.
And I really enjoyed your talk. Thank you very much. So my task is to talk about the lung cancer and this COVID problem we're facing in the world. Okay. Okay. George, the questions will be at the end, okay? At the end of the presentation. You hear my voice, George? I'm mute.
Yes, I do. I'm sorry, I muted myself.
Okay, that's great. So my task is to talk about lung cancer diagnosis and challenges with the COVID pandemic. The agenda is cancer in numbers, COVID in numbers, and the challenges we're facing. So we all know that the challenges we're facing with the COVID is the increased severity and mortality in cancer patients, the psychological impact, the care for patients, the screening and diagnosis, the diagnostic procedures. Okay. Diagnostic procedures and the management. I'm not gonna tackle the immunotherapy in this presentation. It needs a longer time. So, okay. So the incidence, as we all know, and that's was mentioned by the WHO, that the incidence of lung cancer is the top ranking. That's the first in mortality, and the incidence is about 12% or 11.6, the same as the breast as well as the new cancer cases. The mortality, the top of the line is the lung, followed by the colorectal, etc. So we have a lung incidence of number 1 as ranking. And lung cancer is the most common cancer worldwide, accounting for more than 2 million new cases and less than 2 million deaths in 2018. However, in Egypt, the top mortality or the number of new cases is the liver, followed by bladder, non-Hodgkin lymphoma, and then followed by the lung, prostate, etc. I believe our registry should be revised, and we invite, of course, our fellow oncologists and thoracic surgeon, the whole group of oncology, to revise this number, because we have a lot of lung cancer as well in Egypt. The Egypt overview, the confirmed cases are more than, of the COVID, is more than 100,000, I think, but you multiply this number, I believe, by 10 or even 20, because a lot of cases with COVID haven't been registered, and a lot of our patients, they didn't have a PCR examination. Now, let's go to this slide. This slide shows a confirmed COVID patient in a lung cancer, and so it shows the perihilar and as well the subpleural and the mosaic appearance and the GGOs in this slide. And the incidence rates of COVID-19 in patients receiving active treatment for cancer is between around 1% to 4%. And the incidence rate in patients with cancer was found to be higher than the rate experienced in the local community. So let's go into this slide. Some of our patients having this CT scans, there was an incidental detection of lung tumor, as we see here. And this was a case of COVID, but at the same time that it was an incidental diagnosis of a tumor mass, which is very well apparent in the right side with the shaggy edge in a mass at the left upper lobe. So the several systematic reviews have been published estimating the prevalence of cancer in patients with COVID from about 1% to 3.4%. So let's go into the challenge of increased severity and mortality. The evidence suggests that patients with cancer are at increased risk of COVID-19 complications and death compared to patients without cancer. The mechanical ventilation is reported up to the ICU admission with the mechanical ventilation about 40%, 39%. Mortality rate could be as high as 30% in those individuals. The meta-analysis of severity and mortality in different papers showed that the mortality and severity was really high in those patients having lung cancer and infected with COVID-19. In the Chinese, the same thing, Chinese paper, and in the Spanish hospital as well, all of them showed a high mortality and severity. So the recommendations here, what patients with cancer should be self-isolated. We have to minimize activities outside home, avoid unnecessary hospital outpatient visits. Patients should wear, of course, a face mask and disinfect frequently and limit visitors. Another challenge we're all facing, even for those having who don't have lung cancer, the psychological impact. So, as we have seen, patients themselves have been deeply affected by the knowledge of the high risk of serious complications if infected, and cancer patients feel isolated and may experience emotional distress and anxiety triggered by the COVID-19. So, what's the recommendation here? Is to ensure the well-being of patients. We have to encourage and to explore ways to cope with the stress, physical activity, etc., balanced diet, adequate sleep. Virtual community and patient support groups can be excellent sources of encouragement. Another challenge is the care for patients with lung cancer. The COVID-19 pandemic affected healthcare systems globally, as we all know, and this was a very nice paper in about 356 centers from 54 countries and 6 continents, and Egypt was one of the participating countries. And it showed here that the majority of centers, more than 88%, reduced their level of care. More than 10% of their patients missed at least one session of chemotherapy, and patients in many centers, about 60%, didn't have the option of outside care, and physicians followed different guidelines. So recommendations here would be to have a proper patient certification, to certify the risk status of all patients, prioritization of appointments and resource utilization, and I think virtual clinic visits are very important as well. Another challenge is the lung cancer screening and diagnosis. Regardless of whether a patient has a non-small or a small cell cancer, the 5-year survival, as we all know, is less than 20%. And most lung cancers are unfortunately diagnosed in the late stage 3B or 4, and which is likely to be a result of the long interval between the onset of symptoms and diagnosis. All the efforts, unfortunately, of the healthcare providers, especially pulmonologists, were drifted towards the COVID-19 pandemic, resulting in a reduced lung cancer referrals, diagnosis, and suspension of screening. And as we see this, there was a marked drop of the service from 2019 to 2020. If we look at the right side end of this slide, the percent change by cancer site, all patients encountered, there was a drop for all cancer sites, lung, breast, etc., of more than 60%. And in the bottom one, we have a percent change by cancer site, new incident patient encounters or detected more than 65%. So there is a marked drop in the incidence or diagnostics during this pandemic. So there is no doubt that this will have a definitely significant impact on the prognosis and mortality of patients. It will lead to a future increase in patients with later stage cancer, increased demand for cancer screening procedures as delayed tests are rescheduled. Recommendations here would be to consider gradual expansion of our healthcare, prioritize services, prioritize risk populations, and telemedicine. I believe telemedicine would be as well an excellent tool for primary care, triage, and interventions. Diagnostic procedures, that's another challenge. patients with lung cancer often have symptoms which can overlap with the COVID, like cough, dyspnea, etc. And the radiographic findings of COVID may be sometimes indistinguishable, excuse me, from pneumonitis caused by lung, especially those using the TKIs, etc., immunotherapy, radiotherapy, etc. For instance, this patient, he started the EGFR TKI, and it showed in upper lobes patchy ground glass changes with interstitial thickening and a perihilar distribution consistent with a toxic reaction to the immunotherapy. This slide shows as well a PET scan. Can be confusing a little bit. Is it a ground glass opacity due to the COVID, or is it due to cancer? Actually, this was a COVID negative patient, and with a positive PET scan, and on the right side, that was a lung toxicity secondary to the immunotherapy with the TKI medication. Another very interesting paper of radiologists' interpretation of COVID, and it shows a marked difference between 6 or 7, I believe, 7 distinguished radiologists, and all of them showed different interpretation of the CTs. For instance, this was a patient was diagnosed at the GGO as a case of COVID. Actually, it was a non-COVID case, and it was a case of cancer. And this was this patient was diagnosed as a non-COVID case, and it showed that this patient actually had a positive COVID-19 PCR, so that was a COVID. So that was a confusion in the interpretation of radiology, which we all fall in this problem sometimes, even the distinguished and top of the line pulmonologists. So the primary aim of diagnosis in these cases is to obtain tissue specimens for histological diagnosis using the least invasive method. However, bronchoscopy and aerosol generating procedures should be avoided whenever possible to avoid spreading of infection. Elective bronchoscopy should be postponed until full recovery from COVID-19 and having at least twice a PCR negative, unless the patient has a massive hemoptysis, severe airway problem with severe stridor, etc., a substantial endobronchial obstruction, we can proceed with bronchoscopy. Preferably, transthoracic biopsies are preferred than bronchoscopy if it's possible, if it's a peripheral lesion. Non-invasive mediastinal staging with CT or PET scans is preferred whenever possible, but if essential mediastinoscopy may be preferred over bronchoscopy. The challenge as well we're facing in management is that it's a risk of potential life-threatening infection with COVID-19 against the tangible consequences of delaying or not treating a life-threatening malignancy. That's really a problem we're facing. It's a challenge, and the extreme vulnerability of lung cancer patients to the adverse outcomes from COVID, in particular after surgery, chemotherapy, or radiation therapy must be considered. In this slide, it shows that the patients receiving active cancer treatment had a 4.5% incidence and more than 2% mortality. So the different recommendations on the management of lung cancer during COVID-19 pandemic were published by different international studies like the ACCP. I'm not going to go through this, it needs a whole lecture. And for non-small and for small cell, they had a recommendation. We don't have to go through this table. It's in the journals. But this is the recommendation that it has been reported that anti-cancer therapy within 14 days of COVID-19 diagnosis was associated with an increased risk of developing severe complications. Careful consideration should be given by the institution performing adjuvant therapy, particularly in frail patients. And the start of treatment after resection should be delayed for as long as possible, consistent with the adjuvant chemotherapy data up to 12 weeks after resection. That was the recommendation. Recommended systemic therapy should be associated with the reduced risk of myelosuppression, shorter treatment time, and lower frequency of treatment visits. Radiotherapy treatment as well, 5 days per week, could increase, or for several weeks requires daily contact with other patients, and it can increase the risk of infection. Preferably, it should be a hypofractionation. And if clinical resources are strained or if exposure risk is high, radiotherapy could be delayed. But however, at the risk of increased mortality, so risks and benefits need to be discussed among the treatment team and the patient. Another recommendation for the thoracic malignancy for the surgeons by the American Association for Thoracic Surgery, published in 2020. And this were the recommendation that if a SARS-CoV-2 test is positive, surgical resection should be delayed for 2 to 3 weeks if possible. If the patient condition is urgent, it is recommended that the resection proceed within a specialized negative pressure operating room, and all patients should be retested for SARS-CoV-2 when delayed resection is rescheduled. Patients with lung cancer should undergo systematic testing for SARS-CoV at the beginning of treatment and whenever necessary during the course of therapy. And this strategy might be feasible with the increasing availability and progressive use of the PCR assays and IgM or IgG testing to evaluate the exposure and immunity to the infection could be helpful when the pandemic begins to decline. Conclusion, that's my last 2 slides. The COVID-19 pandemic has created a generational crisis and placed an unprecedented strain on our ability to deliver high quality care for patients with lung cancer. Oncology patients deserve particular attention, and as they are immunocompromised and vulnerable to severe outcomes of a SARS-CoV-2 infection. Treatment regimens must be adapted for lung cancer patients, mainly to minimize the number of hospital visits, to prevent treatment complications, and to reduce the risk of infections. Lessons learned from this pandemic should become an integral part of the new regimen of healthcare provided, and implementation of telemedicine would offer a tremendous opportunity to minimize the negative effect of cancer care delivery on public health efforts. And thank you very much for your attention. Thank you. Ahmed. I think if there are any questions for the panelists.